Thank you, Ross, and thank you to the Boyarskys for endowing a lectureship that made it possible to come here. It is a great pleasure to be in Duke, seeing some old friends and new babies, and to come to this wonderful building, which I didn't even know existed, nestled in the trees here. It's just a gorgeous site for a public lecture. I'm going to begin my talk. One of the things I do in bioethics is I do a lot of survey research, and I survey doctors, patients, the public on a variety of questions. I'm going to start out the talk here with an unconsented to survey. That is, you don't have to raise your hand. But first question I want to ask is, considering all aspects, how well do you think the American healthcare system functions? Very well. How many people think it functions very well? Moderately well. A few people. Fairly well. The mode. Not well at all? Well, this is pretty typical of a audience, except when I went to the Massachusetts Medical Society, where a fair number of people said it functioned very well. Considering all aspects, how happy are you personally with the healthcare services you personally receive in the healthcare system? Very happy? Moderately happy? Fairly happy? Not happy at all. That skew, that difference, that on the first question there's no very satisfied or functions very well, and the second half, the fact that you're very happy with your own personal circumstances, turned out to be one of the problems of the current healthcare system and one of the barriers to actually reforming it. And we're going to come back to this at the very end of the talk. I think this cartoon sums it up pretty well. Stuck between congratulations and get well and good luck with the American healthcare system. And I think very many of us feel that. I certainly know that I get that when people call up to me and say, who's the best in X? You know, it's typically cancer, or sometimes it's something else, because they don't trust the system well enough to give them high quality care. The first thing I want to start out with is a broad summary of the problem. The financing system, how we pay for health care, the health insurance structure, is inefficient, inequitable, and increasingly fiscally unsustainable. And I'm going to say a few words about each of those aspects as we go on. The delivery system, that is, the delivery of care, what Duke Medical Center does, is terribly fragmented. It's not designed to care for chronic diseases, which accounts for about 70% of the expenditures in our system. It delivers haphazard and poor quality, and it has a high use of unproven and marginal therapies. Now, true healthcare reform must fix both the financing and the delivery system. You cannot solve the problems we have with our healthcare system by only focusing on one. The unfortunate fact is that most public discussions of this, and particularly at the presidential level, but at almost every public level, is focused almost exclusively on the financing system and getting close to universal coverage. And it almost completely ignores the problems with the delivery system and how to fix the delivery system. Now, if I put you smart people into a room and gave you a piece of paper and a pen to write down what you thought the healthcare system could achieve or should achieve, you would probably have a very long list of things to go on, 25, 30 on your list. But I've boiled it down to 7, and we could argue about them, but certainly the first 3 we can't argue about. We want a system that guarantees coverage for all Americans, 100% of Americans. We want a system that controls costs. We need a system that delivers integrated, high-quality care. We want to have choice. After all, this is America. If you have the choice of 25 different jams, the idea that you wouldn't have choice in the healthcare system seems a bit ridiculous. We also want fair fiscal responsibility. We want a system where those who have more pay more, rather than the reverse, which is our current system, where those who have less turn out to be paying more for the exact same services as the rich get. For doctors and the whole healthcare system, we need malpractice reform. And finally, especially today, we need a system that helps the economy rather than dragging it down. Before we proceed with considering reforming the system, it's good to try to understand how the current system does in relation to some of these goals. Now, all of you have been bombarded with the notion that 47 million Americans don't have health care insurance at any one time in the United States. But probably less well known to you is the fact that 75% of that number are either breadwinners or in the family of breadwinners who have full-time jobs but don't have health insurance. And that's pretty un-American. The rules of our system have been that if you work hard and you're honest, you're supposed to get the benefits of the system. And yet, here it is, 75% of the population doing exactly that and left out of the healthcare system. In addition, 9 million of the uninsured are children, and we can't possibly expect them to pay for their own healthcare coverage. It seems pretty unconscionable that we have a system with so many children outside of it. And then there's the cost issue. In 2006, the last year for which we have very reliable statistics, the U.S. spent $2.1 trillion on healthcare. No, I did not, by mistake, add 3 extra zeros to that number. That's how many zeros there are in that number. 1 out of every $6 in your wallet goes to healthcare, and nothing else. Now, this is a very smart audience, I know that. But the big question is, do you have any grasp how big a trillion is? So, one way of illustrating that is, how many seconds is a trillion? We'll start out simple. How long ago was 1,000,000 seconds? Anyone? There's got to be some math genius here, right? It's last week. So 1,000,000 seconds ago was just last week. 1 billion seconds? The year Richard Nixon resigned the White House. Easy to remember. A trillion? A trillion? 30,000 years BC. That's 15,000 years before the first human stepped foot on this continent in Oregon, right? And we're spending 2 of those every year. It's phenomenal amount of money. But it's not just how much we're spending. It's what I call the tsunami graph. That is, what the graph of spending looks like into the future. Here we are, 2008, right down here, 15 to 16% of GDP. And you can see healthcare spending goes to almost 100% of GDP by 2082 if we do nothing else. Even worse is, this is government spending. And somewhere right around here, Medicare and Medicaid take up all of government spending. There's nothing left for defense. Forget Social Security, the environment, education. Anything else you want? Forget it. It's just Medicare and Medicaid. And that's only 20 years from now. We cannot sustain ourselves on this graph. There are 2 components to these costs. One is the sort of current waste. And administrative waste is a very excellent example. It's mainly from insurance underwriting, sales, and brokerage commissions, and marketing and billing. The fact that you have to sell to each individual or employer creates huge underwriting costs. And then there is the annual cost increases above what we're spending today, that tsunami graph. And 50% of those cost increases above inflation are due to new technologies and the wider use of old technologies. And if you want to control costs, you have to address both of these. This is just a quick example of the administrative waste. 2 economists from Stanford wrote, the need for more than 850 insurance companies to see and contract with millions of employers. Underwriting each one adds greatly to administrative costs. Typically, administrative costs are on the order of 11% of premium, and this does not include the cost to employers to purchase and manage the healthcare spending. To understand how this could be different, consider that Kaiser Permanente signs 1 contract each year for the coverage of more than 400,000 employees and dependents with CalPERS, the California Public Employees Retirement Program, and the administrative cost is on the order of 0.5% of premium. So let me translate a little for you. The difference between 11% and 0.5% is pure administrative waste. No added health benefits, and it's a result of the way we've structured our insurance market, selling to each individual employer. It has nothing to do with the health benefits you get. And as a matter of fact, McKinsey Global Institute estimated that that's at least $75 billion that can easily be gotten out if we just had a more efficient insurance market. What about the delivery of care? And this goes right into the other side of the use of technologies. One problem with the delivery system we have is fragmentation. Last year, there were 1 billion visits to doctors' offices in the United States. 33% of them were to solo practitioners practicing alone with no connection to other doctors or to a hospital. And another third were to groups of 4 or fewer doctors. Now, it's hard for small individual doctors in high-tech 21st century to provide high-quality care. The typical Medicare beneficiary sees 7 physicians, including 5 specialists in a year. And if you have 2 chronic illnesses, you're on average seeing 15 different physicians in a year. Now, how can you possibly get good care that way? We also don't provide high-quality care. Rand did a study not too many years ago, and you may have read about it in the New England Journal of Medicine or other places. And they actually went to hospitals and looked at Medicare beneficiaries who were being discharged from hospitals and assessed whether they got one of 9 very simple interventions. We're not talking here about complicated chemotherapies or complicated surgical procedures. We're talking about, did they get their blood pressure measured, and were they put on a blood pressure medication if it was too high? Did they get their cholesterol measured, and were they on the right cholesterol medication in the right range? Did they get a vaccine for pneumonia? 9 of them. Only half the time, 55% of the time, did they actually get these 9 simple procedures. 45% of the time they didn't. And with kids, it's even less. Only 46% of the time do kids get proven therapies that simple. A fellow federal agencies of ours, AHRQ, the Agency for Healthcare Research and Quality, estimated that of all the Americans who have high blood pressure, only about 30% of them actually have it controlled in the right range. Terrible quality. Unproven therapies. As you heard, I'm an oncologist, but I am a breast oncologist, so I'll pick on the other side, the guys who deal with prostate cancer. As you may know, there's a lot of, there's early stage prostate cancer. About over 200,000 men get diagnosed with prostate cancer each year. And there's several different choices. You can have surgery, you can have radiation, or you could do watchful waiting. And within radiation, there are 4 flavors of treatment. There's 3D conformal radiation, sort of traditional radiation. There's brachytherapy, where they implant seeds into the prostate. There's IMRT, where they try to make the radiation conform more to the prostate even than 3D conformal radiation, and they give you radiation from around 360 degrees around you. And then there's proton beam, radiation that comes from a machine which costs over $100 million and has to be put in a football-sized container facility. And I just learned, actually on Saturday, that that's going at Loma Linda for $80,000 hard cash. Well, given 8-fold difference in price, you might want to know, what's the difference in care that delivers? Well, it's really hard to say. Why? Because there's actually never been a comparison among these 4. There's never even been a comparison among 3 of them. All we have are single institution studies that say, in my experience, and we give you the last 100 patients selected for who knows how. One thing that's for sure, there's no survival difference. Absolutely no survival difference whether you get proton beam, IMRT, or 3D conformal radiation. I know that for a fact because I went to their annual meeting last October. I got up in front of 3,000 radiation oncologists, and I put this slide up and I said, please correct me. Just one of you, just stand up and tell me I am wrong and don't know what I'm talking about. No one took the bait. At best, there's a 10% decline in side effects from 14 to 4%. That's at best. And again, we don't know for sure because of it. And yet, the system is paying for this. Among men 66 years and older, again, with low or moderate grade prostate cancer, who didn't receive radiation or prostatectomy, a third of them got androgen deprivation, that is, either a shot or actual castration. There's no evidence that this improves longevity or survival. It decreases quality of life because, among other things, it makes men impotent. It's not recommended by any of the major guidelines. A third of the time it's being given. And academic physicians are not much better than the guys in private practice. This is outrageous. Let's talk finally about the drag on the economy. The average cost of employment-based health insurance is over $12,000 for family coverage. That is, if Duke hires you and gives you family coverage, that costs you $12,000. That's like hiring another worker at $6 an hour, minimum wage, to give you family health insurance. No wonder employers want out from under this, and no wonder people are doing all sorts of crazy things. By linking health insurance to employment, we've created serious labor problems. Almost every strike of the last decade has been about healthcare insurance, minus one. That's the Hollywood writers' strike. And no one knows what that was about at all. It also creates this problem of lack of portability. If you quit your employment, you might not get insurance. If you want to start your own job, you have this problem of insurance. Those of you who have kids in their early 20s right after college, is a big problem of whether they're covered or not. Creates a huge incentive for outsourcing, both overseas, but to companies here that don't provide health insurance. And it also suppresses wages. Every dollar for insurance as a dollar out of a person's paycheck. So the $2 trillion question is, what should be done about this dysfunctional healthcare system? Now, you heard I work for the federal government, and I am required by the federal government to have this disclaimer. These are clearly not their views. This is a little civics test. You know this guy, but who's this guy? Secretary Levitt, Secretary of Health and Human Services, was governor of Utah before this. This guy? Isn't it interesting you knew Zerhouni more than Levitt? I think there's a message there. How much does Duke get from Zerhouni? He's actually soon not to be a federal government employee in about, I think, 25 days. He just resigned. But not bad, not bad. Well, there is no shortage of healthcare reform proposals in this country. There are scores and scores of them. As a matter of fact, some of you may have heard of something called the Center for American Progress, which is a think tank in Washington affiliated with the Democrats. It's run by John Podesta, who used to be chief of staff for Bill Clinton at the end of his presidency. And they've actually issued 3 different healthcare reform plans, and that's not because the first one was implemented and wasn't sufficient. They just keep issuing. So there's a proliferation of different reform plans, and sometimes it can be confusing to understand them. I believe that there are really only 4 flavors of healthcare reform, and everything can be slotted in more or less into one of these 4 different flavor healthcare reform plans. Guaranteed Healthcare Access Plan, that's my plan. I'll talk about that first. Incrementalism, I'll talk about that. Individual and employer mandates, what they're trying in the Massachusetts, and then single payer plans. Now, I will also evaluate each one of them completely objectively. So, our plan has 10 basic principles to it. The first is that every American receives a certificate to obtain a standard benefits package through an insurance company for a health plan. The standard benefits package starts out being modeled on FEHBP, that's a fancy way to say Federal Employees Health Benefit Plan, that congressmen and senators get. It also happens to be what I get through the NIH. It's a very good health plan. It's better than what 85% of the population actually gets, certainly better than Medicare. Health plans have to guarantee issue, that is, if you want to go and get your coverage, they have to give it to you. And there's no pre-existing exclusion. They can't say, well, you came in with diabetes, we're not covering your diabetes. In return, they are paid a risk-adjusted premium. That is, they're paid more to take care of sick people and less to take care of healthy 20-year-olds. Second, Americans would have free choice of any qualified plan. In most places that are relatively big, they have 5 to 8 plans. New York, they might have up to 20, and in North Dakota, probably 1. Americans who don't enroll get randomly assigned to a health plan. There is no barrier because there's no premium and there's no deductible. So there's no fiscal barrier here. The certificates or vouchers are paid for by a dedicated value-added tax. That is, the VAT is funded exclusively for health care. No general revenue is put in, but also the VAT can't be diverted to Social Security, the environment, the war in Iraq, or whatever else. Excluding Medicare and Medicaid, it starts out at 10% and then will grow to 15%, and I'll talk about that in a second. Fourth, Americans would have freedom to purchase more services if they wanted a wider selection of doctors, a wider selection of hospitals, complementary and alternative medicine, maybe better mental health benefits, maybe more experimental therapies. They could get that with after-tax dollars. There is no barrier here to concierge medicine. 5, the private sector organizes and delivers care, and they set up the networks, but they have to provide the standard benefits package as defined. We eliminate the tax exemption for employment-based insurance. Right now, those of you who are insured through your employer in this room, you don't pay tax on that health insurance. You don't pay income tax and you don't pay payroll tax. That is grossly inequitable, and we can talk about that if you want. We're getting rid of that employment-based exemption, and it's actually the single biggest tax exemption in our system. It's twice as big as the mortgage deduction, for example. 7, we phase out Medicare and Medicaid and SCHIP and all other government programs. What does phase out mean? Anyone who's on the program can stay on the program or decide to go into our Guaranteed Healthcare Access Plan, but there are no new enrollees. If someone turns 65, they don't go into Medicare, they stay in the Guaranteed Healthcare Access Plan. Over about 10 years at most, the plans would shrink down and then be eliminated. 8, The administration and oversight is by a national health board and 12 regional health boards modeled on the federal reserve system. That is, the people who are appointed have long, staggered terms that aren't tied to congressional recall, and they have a fixed budget set by the VAT, not set by annual congressional appropriations. That gives them power to make tough decisions. The boards have to set standard benefits package, ensure this insurance exchange where people get to select which company they want, regulate the health plans, make sure they're actually offering the benefits, and report to Congress. 9, we created an Institute for Technology and Outcomes Assessment that does 2 things. First, it evaluates new interventions like proton beam for prostate cancer and determines its value. And second, it collects and disseminates patient outcome data in health plans. So it monitors, for example, what proportion of people with diabetes in each health plan have their A1C below 9 or at 7. Finally, there's a Center for Dispute Resolution and Patient Safety with each regional health plan that has 2 responsibilities. First, to adjudicate claims of patient injury and to quickly compensate them, and to promote proven patient safety measures so you don't have as much malpractice as the current system does. So one question is, how does this plan compare with the 7 goals I mentioned at the start of the lecture? First, with regard to guaranteed coverage for all 100% of Americans are covered, regardless of income, age, job, health status, or any other characteristics you can think of. With no premium barrier, no deductible barrier, there's no reason people aren't in a health plan, and they are, even if they don't sign up, allocated to one. So everyone is covered. There is no crack in the system by which people can fall through. Controlling costs. Well, at one level, we eliminate or reduce costs from insurance underwriting, sales, and marketing. We eliminate income-linked subsidies. Every time you have to determine whether someone has an income sufficiently low to qualify a program, actually costs a lot of money. And finally, we eliminate the need for businesses to manage the health insurance product. We actually in this country have no idea how expensive that is, but it isn't free. HR departments do a lot of this. Integrated high-quality delivery system. Health plans would provide the infrastructure, information, and incentives for more integrated and coordinated care. They have to report outcomes to that institute I mentioned, which would provide a huge incentive to them for creating computerization and beginning to have more integrated delivery systems. They'd have to provide a standardized benefit for a fixed premium, and that would provide an incentive to them to cover only interventions that pass the technology assessment and to eliminate wasteful or valueless interventions. Most importantly, you as a consumer, not your employer, not the government, could decide which plan you want to go into. If their customer service is terrible, you walk, and you walk with your premium. And this actually can have a huge incentive even if a small percentage of people walk, which we can explain later if you want. Freedom of choice. Americans have freedom of choice of their doctor, their health plan, but also whether they want to spend more money on health care and get better or wider services. Fair financial responsibility. You can't evade a VAT. If you buy things in this country, you are going to pay a VAT. And the more you consume, the more you pay. The average American family, median income in the United States is about $50,000, would pay $4,500 or less for a benefit that is worth $12,000. That is a hallmark of progressivity. Malpractice reform. As I mentioned, the Center for Dispute Resolution solves a malpractice problem. They have authority and resources to introduce system-wide patient safety measures to reduce the rate of errors. Right now, we know a lot about errors, and we know a lot about patient safety measures, yet there's no organization that has responsibility for implementing them and has resources to do it. Finally, they also provide quick payment to people who are harmed and reduce the need for physicians to have malpractice insurance at all. You just take this money directly out of the premium and eliminate the need for malpractice insurance. Finally, helping the economy rather than dragging it down. Business no longer pays for healthcare. This should eliminate the incentive for outsourcing and allow the hiring of more workers. It would reduce labor management conflict over health insurance, and it would provide you as a worker complete portability. You don't like your employer? It's not health insurance that's keeping you there. It also has this great advantage for you of reducing many taxes. One of the things most people don't appreciate is that healthcare has now become the #1 item in state budgets. On average, across the country, 32% of state budgets go to healthcare, whether Medicaid, S-CHIP, or insurance for state workers. Under our plan, that is eliminated virtually overnight. Just imagine what happens to state income and sales taxes under those conditions. The Medicare payroll tax will go down. In addition, because your employer is not providing health insurance, most of us will get a pay increase equivalent of what they were paying before. So you're probably sitting, well, this sounds too good to be true. He's another politician, smoke and mirrors. At least he's related to another politician. This is just smoke and mirrors. Well, so one question you have is, what's the economic feasibility here? So let's look at what the current system is spending and see if we can finance the Guaranteed Healthcare Access Plan for that same amount of money. The last year for which we have data on the current system is 2006. At that time, the employment-based coverage was spending $723 billion to cover Americans who got their coverage through employers. That's what employers paid, and that's what workers paid out of their pocket for their contributions to premiums. Medicaid S-chip, excluding long-term care, excluding the nursing home portion, was another $269 billion. And various other safety net provisions, there are actually hundreds of billions of dollars in these various programs, but you can cut at least 10, and most people think up to $50 billion there for added benefits for pregnant women and children, and some other safety net programs for hospitals in poor areas. The absolute minimum that we're spending on non-Medicare patients, so anyone under 65 in this country, is over $1 trillion. So I think the question to me, and an advocate of our plan, is, can we convert everyone to my plan for this $1 trillion? That, I think, is the challenge of economic feasibility. And the obvious answer has to be yes, or I would not be showing this slide, right? So, on this matrix, this is the population under 65 years old. We'll just assume you can fold Medicare in dollar for dollar for the $500 billion we're now spending on Medicare. Individuals under 65 who aren't part of a family, 41 million. Families of everyone under 65, it's another 65 million. Here's the annual premium in 2006 dollars for the FEHB plan, which is a high-end PPO, Blue Cross and Blue Shield provided plan that is, as I say, high-end. It's the PPO plan with the least co-pays and deductibles. And here's what the annual premium was in 06. And you can see the total annual cost, when you just multiply these numbers out, $944 billion. Now, I assume some of you are pretty smart out there and are thinking, well, people who are on Medicaid, they're not like federal employees. Part of the reason they're on Medicaid is they're sick and they will use more services. And that's absolutely true. And I can show you, but round about $50 billion in more services. So you add up the previous $944 billion, this $50 billion, and you come, for close enough for government work. It's $1 trillion. It's just what we're spending today. So no doubt you're saying, well, how does he do that? He provides a better health care plan to people at the same amount we're spending today, and yet today we exclude 47 million people. Well, a large part of it is just a better insurance market. That $75 billion I mentioned at the start about the administrative costs in the insurance market, that is completely eliminated in our system. There's no underwriting to any individual, there's no sales necessary, and there's certainly no broker commissions under our plan. And that is a lot of money right out of the box. That's how you can get this. In addition, there are some people who have richer plans. If you look at the UAW plan, you look at most executives, they have actually plans that are better than the federal employee health benefit plan, so you're bringing some people down. For the long-term cost control, there are 4 very important mechanisms. One is, there is what I like to call the fiscal rheostat based on the dedicated VAT. If you link the benefit package to a dedicated tax, you can't go beyond the tax. And that creates some fiscal discipline, unless, of course, the American public wants to increase the VAT rate and pay more taxes. Given our great love of taxes, how often do you think that's going to happen? We'll also lower demand by requiring any additional services over the standard benefits package to be paid for with after-tax dollars. Competition among health plans will lead to heavy emphasis on cost-effective care and reducing costs. Systematic technology and outcomes assessment will change the delivery system. And this, I think, is actually the most important thing for the future. Right now, drug companies are working on drugs that they're thinking about getting to the market in a decade from now. And they have to make lots of bets. Will it be covered? How much are we likely to get? What's the efficacy of this drug likely to be? Is it going to add a few months, or is this really going to be a cure for this disease? By telling them that we're going to have this technology assessment plan and this structure to the health system where individual health plans can evaluate the efficacy of their drugs and decide whether they're going to cover them, you send them a message. You know, that next cancer drug that acts 4.7 months to life, it's probably not going to get covered, and certainly not at $55,000 for a course of treatment. They will change their research priorities and what they work on, which is, as I mentioned, 50% of healthcare inflation is all about technologies. That's the Guaranteed Healthcare Access Plan. Let's shift to the other three alternatives. How do you compare it? First is incremental reform. And this comes under a variety of flavors. One is we're going to expand S-chip to all children. That's a bill that's been before Congress multiple times and will be passed in January, probably 21st, 2009. Electronic medical records. We ought to get all hospitals and doctors' offices hooked up with electronic medical records. Will save a lot of money. We ought to shift to medical savings accounts so that people have to spend the first $5,000 out of the savings account, and then if they hit the $5,000 limit, they have full coverage for whatever insurance is. Well, the main appeal of these incremental reforms is not the quality or adequacy of the reform, but their political feasibility. No one who advocates incremental reform says it is the best healthcare reform. They say, well, we can get it through Congress. Given how well S-chip has passed, you really wonder about their political judgment. This is really, though, the triumph of politics over policy. No one thinks this is good. Everyone thinks something else is better, and yet this is what we're going for. It makes no sense. I would just leave you with this thought. Incremental reform is business as usual. Since we have had Medicare for 40 years, we've been doing incremental reform. We've implemented DRGs to pay hospitals a fixed amount for someone staying in. We've implemented now the pharmacy benefit for Medicare, all sorts of other changes with managed care in the 90s. We've been doing these little tinkerings. Is the system better than it was 40 years ago? Or more importantly, if you like the current system and you think it just needs some tinkering, you know, go to the Massachusetts Medical Society, but you're here at Duke and you didn't like the current system. It's not clear to me why you would like this kind of reform. Well, let's look at McCain's health plan, because it really is a version of this incrementalism. He wants to eliminate the tax exclusion for employer-based insurance, just as we do, so people would now pay tax on their insurance provided by employers. And actually, Barack Obama has been attacking him on this point. In exchange for that, he would provide people with a tax credit, $5,000 to a family and $2,500 to an individual, to go out and buy insurance. And it wouldn't matter whether they got their insurance through their employer or they got their insurance on their own. And then he wants insurance companies to be deregulated, more or less, to allow them to sell insurance across state lines. So a Nevada insurance company could sell insurance to someone here in North Carolina, and you therefore wouldn't have protections of the state insurance regulator in the same way. He's got a number of other things. These are sort of what I like to call apple pie and motherhood, because everyone has these same things. We need more electronic medical records, a little disease management, some pricing transparency so you know what your cabbage costs, reimportation of drugs from Canada, and then he adds this zinger, that state insurance pool for people with pre-existing conditions. Because if you go out and you have cancer and you want to get insurance, there's no way if you're all alone, because it would cost you $30,000, $40,000, $50,000 and you just can't afford it. So for those people, he wants states to have this insurance pool that would cover them, but he doesn't actually indicate how he's going to pay for it. As I mentioned, this is incrementalism. Now the interesting thing is, if you go to his website and you read some of his speeches on healthcare, the amazing thing is he has a very sophisticated understanding of the problem of the system. Really sophisticated, and his primary policy advisor, Doug Holtz-Aiken, is a very smart guy on healthcare. And you would be amazed. If you heard him, you'd say, this guy really understands the problems of the system. The only problem here is the solution doesn't match the problems. It doesn't even attempt to achieve any of the goals. Not universal coverage, not cost control, and not improved quality. So here's the evaluation. About 20 million people would shift out of employment-based coverage. So people who are covered by Duke now, who are around 20 or the early 30s, they would probably quit being covered by Duke, get that insurance tax credit, and go into the individual market, because they would have good risk and could get a cheaper product. So about 21 million people would go into the individual insurance market. So we have a net gain under the McCain plan, 1 million people. Not a big dent, 2.5% of the total problem. But the individual market, you go out and try to buy insurance, has three really bad problems. First is, almost no matter what, you're going to get less health benefits with higher deductibles and copays. Every comparison between the current product in the individual market and what you get from your employer shows that you get less health care coverage in the individual market. Second, much higher administrative costs. If you don't like waste, if you don't like so-called administrative waste, this is a disaster because they have to not only underwrite all of Duke, they'd actually have to underwrite you. 45-year-old woman with these kind of healthcare problems and figure out what the premium is. That is terribly inefficient. And given this lack of state protections for insurance companies, your protection, if you have a pre-existing condition or if you're harmed by your insurance company in any way denied services, much worse under this system. Second alternative to the Guaranteed Healthcare Access Plan are mandates. And mandates rely on three basic structural principles. First, it requires individuals and or employers to buy health insurance, even if only catastrophic coverage through high deductible plans. In the 90s, when Clinton proposed his health care reform, it was employer mandate. Now, it's more shifted to individual mandates. Insurance exchanges create this exchange where people can go in and every insurance company has to offer the same product, has to guarantee issue, has to have no pre-existing exclusion, and allows people to go in and basically eliminate the underwriting and sales and marketing costs. And finally, if you're going to require people to get coverage, even if the coverage is somehow a little cheaper because of the insurance exchange, you have to provide subsidies, especially for those people who are poor. And the typical proposal provides subsidies to anyone up to 300% of poverty, since many of you probably don't keep the poverty number at your fingertips. That's about $63,000 per year. And other plans have a subsidy to small businesses. The additional cost for these kind of healthcare proposals, if it covers the whole country, an added $100 or $150 billion per year, depends on a little how much you calculate. You're going to have to add more services or sweeten the pie or add better subsidies to people. But it's certainly not revenue neutral like the Guaranteed Healthcare Access Plan. You have to add more money. And the main reason is there's no administrative savings here really at the employer level. Now, people have called this plan a fill-in-the-cracks reform, arguing that it relies on the current system and tries to get as few changes as possible to get as close to universal coverage as possible. Now, you might think those were my words, being a little critical of this plan. In fact, those are the words of Jonathan Gruber, the MIT health economist who came up with the Massachusetts plan. This is how he sold the plan to John Edwards in January 2007, so Edwards adopted it, and it became the standard Democratic plan. I know he said those because we were on a phone call debating with Edwards about which plan he ought to have. And Gruber said, look, for political reasons, you want to make as few changes to the system as possible and keep as much as you can. So how does this stack up against the goals that I mentioned? Coverage, you never get to 100%. Never, ever, ever get to 100%. At best, you get to 97%. Currently in Massachusetts, the last number which I saw, they're at 95%, maybe a little lower. Why is that? Well, you've got this mandate that people should buy coverage, but you're only going to subsidize up to 300%. So people earning between $60,000 and $80,000, they're not poor by American standards. But now you're asking them to buy a $12,000 product. You're requiring them to spend $12,000 a year. So what do you end up with? You have to say, well, it's unaffordable for them. They're not going to be required to be in the mandate. And that typically is going to be 3 to 5% of the population. It also may well be that a number of young people decide they're not in this game at all. Controlling costs, not a whole lot done here. Minor efficiency because of the insurance exchange, but again, it still keeps the employer in the game almost to the hill, and so there's no real cost control. Finally, they don't have any real way to affect these technology assessments and other incentives for companies and providers to be more efficient. Integrated delivery system relies on the current delivery system. Very little change. Freedom of choice. It's better for the people in the insurance exchange, but most people don't get into the insurance exchange. They stay with their employer. Fair fiscal responsibility. It uses the same taxes as we have today. Actually, several of the proposals, including John Edwards', wanted to fund this by a payroll tax. There is no more regressive, awful tax than a payroll tax. Huge disincentives to business to add hybrid. This is not fair. It actually turns out to be terrible for the economy. And this plan does not do much for controlling costs and relieving businesses of some of the costs. Now, the preliminary experience in Massachusetts confirms these worries. As I mentioned, they're not getting anywhere near 100%. 95% is certainly better than 89%, which is where they were when they started. But let's not confuse 95% with 100%. And this is structurally made as a plan that will not get to 100%. But the real problem is going to be this cost control. And it's going to make it unaffordable for employers in the state. I think there's this dilemma. Rising costs in healthcare will mean employers would rather get out of the system and pay whatever the penalty they have to, rather than continue to participate in healthcare. In fact, that incentive is going to get worse for them as healthcare costs go up and as the economy goes into a recession. This then puts a burden on the state to provide more subsidies to people to buy their health insurance, and then you get the dilemma, which is the state either has to raise taxes to provide the subsidies or declare more people out of the mandate because health insurance is not affordable. And that is, what happened in Massachusetts. They had to spend $200 million more than anticipated, so they just jacked up taxes on cigarettes. At some point, even the good people of Massachusetts are going to become fed up with this and say, Mas, we've had enough. As a matter of fact, there is a ballot initiative in Massachusetts about taxes. And I don't think it's, unrelated. Here's the head of their insurance exchange, what they call the Massachusetts Connector, saying, Massachusetts insurance plans to raise rates 10 to 12% next year, 2008, twice this year's national average. If we continue with double-digit inflation, I don't think healthcare reform is sustainable. This is the guy who's running their healthcare reform saying it. What about Obama's plan? It really is a version of these mandates. He requires all families get coverage for children, and then he has this pay-or-play option for large employers. Either you provide insurance for your workers, or you have to pay a penalty to the national insurance plan. He provides small businesses a 50% tax credit if they provide insurance to their workers. I might say small businesses like law firms or doctor's offices who provide coverage, they're now getting a lot of money to do it. Small businesses who have employees that work at minimum wage or just above and aren't, even with this 50% can't do it, they don't get that benefit. Just think about the income distribution of that. He also has a national health plan open to people who do not have employer insurance or any public program and small businesses. It's got a standard benefits package like the Federal Employee Health Plan, guaranteed issue, no pre-existing conditions as we suggest, but it provides income-linked subsidies so that you get more money the poorer you are to buy into the plan. And there's a national insurance exchange to offer the national health plan as well as any private plan that wants to cover these people. Other provisions, you've seen this list before. This is the McCain list. So you can see the widespread consensus. It has some advantages, which is the National Health Plan, Medicare, and the Federal Employee Health Plan are supposed to have some performance goals of reporting their quality measures. There's $10 billion per year for IT. He just doesn't say we want records. He says the federal government's going to spend this money. So Obama's plan is, I think, mandates light. Why do I say light? Because there's no mandate on adults, just mandate on kids. It improves coverage at most to 95%, and the overall cost estimated is 1.6, that should be trillion, sorry, over 10 years. Other problems, little cost control. The IT and disease management alone are unlikely to save money in the near future. It's estimated that if you put IT in every doctor's office, you get savings back about 5 to 10, 15 years. There's no mechanism in this plan to impact technology development or diffusion. And there actually might be some cost push. If the National Health Plan becomes the standard, then every drug manufacturer, every disease advocacy group, every device manufacturer knows they got to get their thing onto the National Health Plan. That's how you get coverage. That's how. And if you don't, you're out of business. Just imagine the political pressure to get it on that plan. And he hasn't really thought through how you're going to insulate them. There is some impedance to quality because of the measurement in the federal programs. Last option, single payer, goes by the Medicare for All or the Physicians Working Group for Single Payer National Health Insurance, otherwise known as Canadian-style single payer. Again, three main foundation stones. One, a single national health plan, public plan, covering all Americans for all medically necessary services. You reduce administrative costs because there's no insurance company. You eliminate all the insurance company with a single national plan, and you therefore reduce the administrative costs down to what Medicare is, about 3 or 4%. Finally, you have cost control over time because you use the same reimbursement as Medicare has. Physicians are paid by fee for service, and drug formulary, there's a single national drug formulary, and you negotiate prices. So the cost control is we can pay doctors, we pay hospitals, we pay the pharmacists, and we will just set the prices arbitrarily and ratchet them down. The best way to think about single payer is radical reform of the financing system tied to the 19th century fragmented horse and buggy delivery system that we have now. This is not progress on the delivery side at all. Let's look at how it matches the goals. Coverage, 100% coverage. Everyone's in the system. There's no fiscal barrier. Freedom of choice, you can go to any doctor, any hospital you want. Except you can't choose particular insurance products. You can't choose to pay more. Helping the economy, it certainly removes the employers, but there's really no cost control in this. The key problems are no integrated delivery system, no or a failed cost control mechanism, and politicization of decision-making, which is built into the way they think about this. Reform of the delivery system, as I mentioned, requires three things. Infrastructure for coordinated and integrated care, mechanisms to bring doctors and nurses together with hospitals, pharmacists, home health care agencies. You need an information system to go across all those providers taking care of the same patient and to measure outcomes and how well the system's doing. And we know in the current system, you want those two things, they don't happen spontaneously. Therefore, you need incentives to actually get these people to work together. We know that doctors will not play on baseball teams unless they're the captain or paid to. And that's what you need. Now, you can call it whatever you want, but you're going to have some organization that looks a whole lot like an insurance company to take on risk and to provide that integration, information system, and incentives. Single payer is against those kind of organizations. They continually say administrative costs with no health benefit. More importantly, in my view, it institutionalizes the fee-for-service delivery system, which does not provide an incentive in any way. It actually provides the incentive for why we have the fragmented system we do now, because people get paid piece rate. The main mechanism of cost control in single payer is to set prices for doctors, hospitals, home health care agencies. This is a failed cost control mechanism. We know that providers game the system every time. Finally is decision making. When single payer advocates imagine the administrator for this system, I think in the back of their head is this guy. But you have to, and if the current administration has suggested anything, you have to think about what happens if it turns out to be this guy. I mean, you just have to build a system that's not dependent on who's running it. Hal Luft, a health economist out on the West Coast, wrote in JAMA recently, Medicare, which provides near universal coverage to U.S. residents 65 years and older, is the prototypical single-payer model and routinely exhibits the problems of the model. Although permitted to arbitrarily set fees, Medicare has found it difficult to do so effectively. Across the board, fee changes elicit broad-based political reaction. Narrowly focused changes draw sub-rows of special interest lobbying. Patient advocacy groups, often supported by industry and specialty societies, encourage coverage for specific services. Rather than market discipline, Medicare is subject to political manipulation and bureaucratic rigidity. Single-payer advocates envisioning an equitable and efficient healthcare system idealistically disregard the example of Medicare and the ethos of the U.S. political system. In my view, they have their targets set on the insurance industry and drug companies so much they haven't thought through what happens if you create another institutional structure. How do you protect it from politicization and the other problems? Let me conclude tonight's talk with practical politics. I've been in Washington for 10 years. I have a PhD in political science, and I have a brother who's a congressman. I don't think I'm looking through rose-tinted glasses. So I want to be very frank with you about the barriers to change. There are 4 major barriers to change. One is the one we started with in our survey. 85% of Americans have some kind of health coverage. And you actually are well satisfied by what you've got, personally. Therefore, you are resistant to change. And it turns out that among voters, it's 93% health coverage because the uninsured don't vote very much. That in and of itself is a problem. I was on the phone today to a U.S. senator talking about this, and he said, you know, one of the problems is people hate change, and they hate change away from their current system because they don't know about the next one. Then there's the James Madison rule of government. James Madison designed the Constitution to make sure nothing happened. He wanted to prevent tyranny, and he wanted to have checks and balances to check every special interest. You got to pass a bill in the House committee. You got to pass a bill in the Senate committee. Then the House has to vote. Then the Senate has to vote. Then you need reconciliation. Then the president can be yada yada, right? We've seen how we reacted in an emergency in the last few days. Gridlock, right, is the way the government was designed in this country. That makes it hard. And one of the solutions that you're going to see about the bailout is attach that bill to a tax cut. You can't have a congressman vote against a tax cut. So you can get a $700 billion bailout of Wall Street only by attaching it to a couple of $1 billion tax cut for Americans. Brilliant. The third one is the Machiavellian rule of reform. As a political theorist, I like this best. There is nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. For the reformer has enemies in all those who profit by the old order, and only lukewarm defenders in all those who would profit by the new order. After all, if you're going to be shut out of the system and you are making money today, you're going to fight tooth and nail. And those who might benefit by the current system, well, it's a little hypothetical. I don't know if it's going to pass. Not sure about the benefits. So you sit on the sidelines. We've seen this. What were the Harry and Louise ads all about? Finally, there's Stuart Altman's rule of second best. A majority of Americans are for healthcare reform. Poll after poll shows that. But they're divided. Some of you are probably incrementalists, maybe agree with Senator McCain. Some of you like the Massachusetts plan and want to go with that. Some of you probably diehard single payers, and maybe I've convinced one person in the audience to agree with me. But everyone has a second choice. Do nothing. I can't get mine, I don't want anything done. And we saw this play out in California, where various groups said, that Schwarzenegger plan, it's not mine, we're against it. Political scientists, John Kingdon in particular, the dean of studying Congress, formerly at the University of Michigan, he's now emeritus, said that to get change, substantial change in America, 4 things have to come together. First, a problem has to attract widespread public and political attention. Second, a proposal to solve the problem must be agreed upon by the major actors. Third, there's a major actor who wants to champion this through thick and thin over the course of many years. Fourth, you need a transforming political event that creates an open policy window through which you can shove the new policy before Congress realizes what it's done. Let's look at each one of these. First is the problem. We have an awareness of the problem in this country, and I actually think, again, if you read Obama's position paper, if you read McCain's position paper, if you listen to senators and congressmen, they really do understand the problem. They understand the delivery side problem, they understand the quality problem, the cost problem. I don't think problem is our problem. Policy. At the moment, we clearly don't have shared or agreed upon consensus in this country. Many key stakeholders have not said what they will accept. Let me give you an example. Most businessmen say, oh, the healthcare system's terrible. But ask them the question, so what are you for? They haven't come off the fence. They are partnering with lots of people about, we need healthcare reform, but you don't know what they're for. Champion. In my view, we have lots of champions, but we don't yet have the right champions. 3 groups have to get into this game in a serious way. We need the business community, as I say, to say what they're for and to begin pushing. We need governors. Governors are handcuffed by the current healthcare costs from doing anything innovative in their state. I am amazed that they haven't taken more initiative about the federal system. And finally, patient advocates. I have been asked more times in the last few months to begin addressing patient advocacy groups because despite most of them being well insured, they are paying now astronomical amounts of money, including the AARP, that represents elderly people. The increase in premiums and deductibles is really getting to them. Transforming political event. By its very nature, this is unpredictable. Not only can't you and I predict it, turns out politicians are even worse than we are at predicting when these transforming events are going to hit. So we need to be ready when that moment happens with the policy that people agree on. I think the current fiscal crisis may be the transforming political event that opens the policy window. And I didn't say this just a few weeks ago. In point of fact, at meetings like this and speeches, I used to say it's 2013, we're not there in 2009. Here's a thought for you. This current fiscal crisis is first going to end the epithet, socialized medicine, to any reform proposal that has a bigger role for the federal government. If you socialize Freddie, Fannie, AIG, and most of the mortgages insurance on Wall Street, who's going to talk about the fact that we're going to have a bigger federal fiscal role here as socialized medicine? It just doesn't hold water anymore. So I think we might have a more thoughtful discussion about reform. Second, if you're spending $700 billion on banks, it makes $200 billion look like chump change. You know, you always need a perspective. And I think, $200 billion make people nervous, but $700 billion, if we can do that in a couple of weeks, $200 billion, maybe it's not so bad. We can swallow that. Because of this fiscal crisis, we are going to have a serious recession and higher unemployment. There are easy projections now. It's going over 7% by even the most cautious people. And that'll force Americans, or Americans will then want fiscal security and financial security, and healthcare reform is a key element of that. And I think it answers a yearning issue for them. Fourth, that desire for security in the face of fiscal winds that people can't control will make Americans settle for a more basic benefits plan rather than the gold-plated comprehensive, full-bore, we're covering everything under the sun. And I think if we can get a basic plan, it makes it more sellable to the other side. Employers, they're going to be facing a much worse cash problem, and I think getting healthcare off their books, especially the healthcare increases in years ahead, is going to be very attractive to them. And finally, there are the deficit hawks. Debt pressure is going to push us towards more comprehensive reform rather than incremental reform. The only healthcare reform plan, the only one that has been scored as revenue neutral and then cost saving, is the more comprehensive Wyden-Bennett bill, rather than these incremental reforms. All of the healthcare reforms, whether it's mandates or incremental reforms, cost a lot more, tens or hundreds of billions of dollars. The Wyden-Bennett bill, which is very close to our guaranteed healthcare access plan, actually is fiscally saving, because you know what you're spending and you've got a hard backstop to it. Thank you very much for your attention. Those of you who want more information about our health plan, there are two guys out in Seattle running this website and trying to get people politically engaged. Those of you who want more details, maybe about the financing of the VAT or technology assessment or how you would administer it, if you really want to go to sleep with a paper, just quickly go to sleep. FreshThinking.org has a lot of papers that will send you right to bed. And then, as mentioned, I have a new book which outlines this in more detail, Healthcare Guarantee. Thank you very much, and I think we have a minute or two for questions.